Good day, I'm Dr. Timothy Nazareno and I'm here to discuss the central nervous system neoplasm and tumor-like masses. Let us begin with the epidemiology of intracranial masses. So the overall annual incidence in the United States amounts to 20,000 cases. 80 to 85% of these cases occurs in patients older than 15 years of age. 70% of all intracranial tumors are located within the supratentorial region. 30% are due to metastatic lesions, and 70% of tumors in 1-year-olds to adolescents are located in the posterior fossa. The World Health Organization has classified intracranial tumors into 7 major categories and is based on the cell of origin. So the different groups include neuroepithelial cells, tumors that grow from the nerve sheath, meninges, lymphoproliferative cells, germ cell tumors, tumors of the sella, and metastatic intracranial neoplasm. Whenever we talk about intracranial neoplasms, it is important to know where is the location of these tumors. So we categorize a tumor either an intraaxial tumor versus an extraaxial tumor. An intraaxial tumor are tumors that are located or arising from the brain parenchyma itself, while those of extraaxial in location occurs at outside the brain parenchyma. So examples of intraaxial tumors include astrocytoma, glioblastoma multiforme, and oligodendroglioma, while extraaxial tumors include meningioma, arachnoid cysts, craniopharyngioma, and macroadenomas. If we suspect that the patient has an intracranial neoplasm, we should check the patient's signs and symptoms that he or she is presenting. So majority of intracranial neoplasm shows increased intracranial pressure, presence of seizure activity, or focal neurologic deficit. Also, when we are dealing with intracranial tumors, more often than not, there is brain herniation. For example, there could be subfalcine herniation or uncal herniation, or these tumors can obstruct the pathway of the CSF and cause hydrocephalus. When we are dealing with an intracranial neoplasm, we should ask ourselves these questions first. So first and foremost, are we dealing with a mass? A mass should exhibit mass effect, meaning it should displace normal brain structures. Now, the imaging modality of choice that is highly recommended for the diagnosis of intracranial neoplasm is MRI. However, not all institutes have MRI, so they resort to CT scan. Now, an early infarct is very hard to differentiate from a mass when using CT. So, with that, a 3 weeks follow-up time is recommended if only CT is available, because in 3 weeks' time, an infarct could have regressed while a mass could have persisted. Once we have established that a neoplasm is indeed within the brain of the patient, we locate it either is it in the intraaxial or extraaxial region. So as I have said a while ago, intraaxial masses are within the brain parenchyma while extraaxial masses are seen outside the brain or can be within the ventricular system. So usually the signs we look for extraaxial masses include white matter buckling or inward compression of the white matter, while the gray-white matter differentiation is maintained. Now, for an intraaxial mass, it expands the white matter. Now, next is the tumor margins. However, histologic examination of a brain tumor could provide the answer for this question. So, for the diagnosis of intracranial neoplasm and tumors, MRI is still the best imaging modality that is used due to multiplanar capability, increased contrast resolution, and lack of ionizing radiation. However, in cases where we are assessing the presence of calcification or affectation of the adjacent calvarium, CT is more superior when compared to MRI. Now let us begin with the discussion of intraaxial tumors, which of glial in origin. First is astrocytoma. So this represents 70% of all gliomas. Now these tumors are graded according to 5 histologic features including cellularity, mitotic capability, pleomorphism, presence of necrosis, and endothelial proliferation. By using the previously mentioned criteria, we can grade the tumor into four grades. So for grade 1 tumors, it is a well-circumscribed lesion on imaging and in gross pathologic inspection. Example of grade 1 tumors include pilocytic astrocytoma, subependymal giant cell astrocytoma. For grade 2 lesions, it is well circumscribed with low degree of cellularity, mitosis, and pleomorphism, and an example is diffuse astrocytoma. Grade 3 lesions exhibit increased cellularity, mitosis, and pleomorphism, and an example is anaplastic astrocytoma. For grade 1 tumors, it exhibits marked cellularity, mitotic activity, and pleomorphism, and presents with extensive areas of necrosis and endothelial proliferation. Its examples include glioblastoma multiforme. Gliomas may spread via the white matter tracts such as the corona radiata, corticospinal tracts, corpus callosum, and hippocampal commissures. They can also spread via the Virchow-Robin spaces or along the subpial and subependymal surfaces, and rarely, they can also spread via the meninges. The most malignant of the gliomas, the glioblastoma multiforme, is the most common type of astrocytoma. The most common age group that is affected by this lesion ranges from 45 to 55 years old with slight male predominance. Now, the most common location of this tumor is seen within the deep white matter of the frontal lobe. On imaging, glioblastoma multiforme appears as an expansile mass presenting with central areas of necrosis. On post-contrast studies, it exhibits ring enhancement with extensive edema. It can also present with areas of bleeding and sometimes called butterfly glioma due to the presence of bihemispheric spread through the corpus callosum with involvement of both frontal lobes. Now for low-grade astrocytoma, it exhibits slow growth and it represents 20 to 30% of gliomas. Majority of patients include 30 to 40 years of age with slight male predilection, and sometimes it can occur in pediatric patients. These lesions exhibit variable enhancement and degree of edema on imaging. Bleed may occur, but necrosis is very rarely seen, and there is poor margination with some degree of mass effect. Next is a rare entity which is called gliomatosis cerebri. Now, it is widespread infiltration of neoplastic cells in varying degrees of differentiation. Now, the criteria is for gliomatosis cerebri to be diagnosed, at least 3 lobes of the brain are needed to be involved. It could represent a diffuse involvement of the cerebral white matter without a mass or one with a discrete mass seen. Oligodendroglioma represents 5 to 80% of all gliomas, and patients ranging from 30 to 50 years old are the frequent patients that are seen with this kind of pathology. 85% of oligodendroglioma are seen in the supratentorial region, most specifically at the frontal lobe, usually with erosion of adjacent calvarium. It is also called a mixed glioma because of mixed cellular origin. Next, we will discuss non-glial intraaxial tumors. Primary CNS lymphoma was once a rare entity. However, due to the increasing number of immunocompromised patients, it has become the fourth most common primary CNS neoplasms and more commonly seen in patients with AIDS. Now, usually these kinds of lymphoma are categorized as B-cell non-Hodgkin's lymphoma, and these masses, interestingly, are sensitive to steroid therapy and radiotherapy initially, only to rebound with vengeance. That's why it is also called a ghost tumor. On imaging, it is composed of tightly packed cells with high nucleus to cytoplasm ratio within the perivascular spaces. Now, this accounts for its hyperdense appearance on CT scan. Now, this mass is also seen near the leptomeninges and ventricular system. 85% of lymphomas are seen at the supratentorial region, while 10% occurs in the cerebellum. The presence of calcification and bleed are rare. Ganglioglioma and gangliocytoma. Now, these are tumors composed of both glial and differentiated neurons, which is called ganglioglioma, or purely neuronal tumors with no glial component, or gangliocytoma. The most common age predilection is 30 years, and ganglioglioma is the most common tumor seen in chronic temporal lobe epilepsy. Cranial metastasis from a primary malignancy is one of the most common central nervous system neoplasms, accounting to one-third of its case. They may be intraaxial, dural, extraaxial, or within the subarachnoid spaces. 80 to 85% of these cases are seen in the supratentorial region, except for renal cell carcinoma, which is commonly seen at the posterior fossa. Majority of cases exhibits multiple lesions. However, in some cases, solitary lesions are seen, and hemorrhagic lesions are common when the metastasis is secondary to melanoma, renal carcinoma, thyroid carcinoma, and choriocarcinoma. When we are dealing with cranial metastasis on imaging, it usually exhibits multiple foci and usually located at the great white matter junction and exhibits marked vasogenic edema. On post-contrast studies, these lesion exhibits intense enhancement which is variable in form. It could be ring-like enhancement or nodular enhancement. Next are posterior fossa tumors. Medulloblastoma is one of the most common pediatric cranial nervous system malignancy, which is usually seen in patients 4 to 8 years old. A majority of cases arises from the cerebellar vermis, and some of which extends to the fourth ventricle, which results to the development of hydrocephalus. This is a World Health Organization grade 4 tumor with rapid growth. On imaging, medulloblastoma appears as hyperdense solid masses on CT scan. The presence of cystic changes, necrotic components, and calcification are usually seen. The presence of hemorrhage is rare. Some degree of edema is present with blurring of the cerebellar foliae. Pilocytic astrocytoma, also one of the most common pediatric cranial nervous system tumors, and is also seen within the region of the cerebellum at 60% of cases and accounts for 85% of cerebellar astrocytomas. This is the most common tumor seen in the neurofibromatosis 1 syndrome or von Recklinghausen disease. On imaging pilocytic astrocytoma, about 66% of these cases are cyst-like with an enhancing mural nodule. The remaining 33% are solid masses with no necrotic center. Calcification occurs in some cases. The majority of lesions exhibits a well-demarcated vermian or hemispheric mass. Ependymoma accounts for about 3 to 9% of all neuroepithelial neoplasms and mostly commonly manifests in children and adolescents. These kinds of tumors arises from ependymal cells that line the ventricular system and the central canal of the spinal cord. Now, 60 to 70% of ependymomas occur within the posterior fossa, with 70% of those cases centered within the fourth ventricle. Curiously, there is a predilection of the tumor to originate within the brain itself instead of the ventricular system when it arises supratentorially. On imaging studies, these tumors are isodent with a mixture of calcification, cystic changes, and even hemorrhage, producing an overall heterogeneous appearance. Let us now proceed with extraaxial tumors. Meningioma is by far the most common extraaxial neoplasm of the adults and accounts for 15% of all intracranial neoplasms, second only to gliomas in overall prevalence. The age group that is usually affected is between 50 to 60 years of age with female predilection. Now, it exhibits benign biological activity, growing slowly and most frequently found in the parasagittal or convexity locations. Other locations include the sphenoid wing, the planum sphenoidal or the ophthalmic groove, the ventricles, tentorium, and optic nerve sheath. This kind of tumors arises from the arachnoid cap cells with some probable contribution from dural fibroblasts and PL cells. According to the World Health Organization, there are 15 types of meningioma identified, 9 of which are considered grade 1, 3 are grade 2, and another batch of 3 is grade 3 tumors. On imaging finding, so in CT scan, it presents as a well-defined hyperdense mass with variable surrounding edema. It exhibits homogeneous enhancement on post-contrast administration, and usually the adjacent calvarium exhibits hyperostosis, and sometimes calcification is a common finding within these tumors. In MRI, this lesion exhibits iso to hypointense signal when compared to gray matter on both T1 and T2 weighted images. Now, heterogeneity is the rule because of the presence of cysts, vessels, or calcifications within the tumor. Now, sometimes prominent PL vessel flow void are seen, and since it is extraaxial in location, CSF clefts are usually demonstrated. Also, this lesion exhibits the dural tail sign, which is the thickening and enhancement of the adjacent dura, and 60% of these lesions exhibit this sign. However, this sign is not pathognomonic of meningioma. In angiography, the meningioma exhibits particular findings which is specifically seen in the arterial face. Now, the lesion is seen as a radial arrangement of vessels with an early dense tumor blush persisting into the venous face. And sometimes, enlarged dural vessels and arteriovenous shunting may also be appreciated. Dural metastasis is the most common form of extraaxial spread of metastatic lesions and is seen in 18% of autopsy series. Now, skull lesions are usually secondary to breast, lung, prostate, or renal malignancies, which give rise to epidural metastasis. For subdural lesions, they are believed to result from hematogenous spread, and in cases of spinal lesions, its spread is secondary from pelvic tumors by way of the Batson venous plexus. Next, we shall discuss intraventricular tumors. On imaging, especially in CT, they are seen as well-defined masses that are iso to hyperdense when compared to the normal brain parenchyma, and typically, these lesions are multilobulated. Choroid plexus calcification in the first decade of life is atypical and suggests the possibility of a choroid plexus papilloma. On MRI, they present as iso-intense when compared to gray matter on T1 weighted images and hyper-intense in T2 weighted images, and enhances markedly in post-contrast studies. For subependymoma, immediately underneath the ependymal lining of the ventricular system lies a thin subependymal glial layer. Now, the tumor that arises from this region is termed subependymoma and is classified as a grade 1 World Health Organization intracranial tumor. Majority of cases are asymptomatic. However, it can cause hydrocephalus or focal neurologic deficits in some cases. More than half of these tumors are seen arising from the fourth ventricle, while 45% are located in the lateral ventricle. On CT and MR, this tumor manifests as a well-circumscribed lobulated intraventricular mass and is usually iso to hypodense on CT with frequent calcification and cystic changes, and is hypointense on T1 weighted images and hyperintense on T2 weighted images. Colloid cyst is not a true neoplasm. It mimics such lesions and characteristically occurs in the anterior superior portion of the third ventricle near the foramen of Monro. It accounts for 2% of all intracranial masses, yet is important because of its propensity to cause acute hydrocephalus as a consequence of foraminal obstruction. The classic presentation is that of acute onset severe headache, which can be reproduced by the patient tilting the head forward, or it is called Brown phenomenon. Now, on imaging, its appearance is variable, but on CT scan, majority of cases appear hyperdense when compared to brain tissue. On MR, it exhibits extremely variable signal intensity and is seen on both T1 and T2 weighted images. Now we'll proceed with the pineal gland masses. Germ cell tumors are the most common type of neoplasms seen within the pineal region and accounts for 60% of all pineal masses. The most common location is seen within the pineal region, followed by the suprasellar region. And germinoma is by far the most common intracranial germ cell tumor, which also occurs in the suprasellar region. These kind of tumors are commonly seen in children and young adults with a peak incidence around the age of puberty. On imaging, in either the pineal or suprasellar regions, germinoma typically manifests as a iso to hyperdense well-circumscribed mass on CT. Engulfment of the normal physiologic calcification is a distinguishing feature of germinomas from the exploded appearance most commonly seen in pineal parenchymal tumors. On MRI, non-specific hypointensity of T1 weighted images and hyperintensity on T2 weighted images is common. Pineoblastoma is histologically and radiographically similar to medulloblastomas. It has been categorized as part of the pinate family by some neuropathologists. It occurs primarily in young children, although it may be seen in patients up to 30 years of age. The tumor is highly malignant and is classified as a grade 4 tumor. Rarely, it may occur in combination with bilateral retinoblastomas to constitute the so-called trilateral retinoblastoma. It is usually seen as a lobulated mass with local invasion and frequent calcifications. Now we will proceed with cellular masses. Pituitary macro or microadenoma. These are 10 to 15% of all intracranial tumors and the most common suprasellar mass in adults. It measures greater than 10 millimeters if it's macroadenoma and less than 10 millimeters in size if it's a microadenoma. 75% of these cases are hormonally active, while the remaining 25% represents non-secreting adenomas and are usually macroadenomas. Among these, prolactinomas are the most common secreting adenoma. MRI is the preferred imaging modality for these types of tumors. Not only would it be able to delineate the mass exquisitely, but also clearly visualize the optic chiasm, anterior cerebral vessels, and cavernous sinuses. Overall, signal characteristics of pituitary tumors can significantly vary depending on the components. It may contain hemorrhage, cystic changes, or necrosis. Larger lesions are often heterogeneous and vary in signal due to areas of cystic changes, necrosis, or hemorrhages. A macroadenoma growing superiorly out of the pituitary fossa will contract, elevate, and compress the central part of the chiasm in most individuals. The central part of the optic chiasm carries fibers from the nasal retina and thus result in the classical bitemporal hemianopia. As I have said previously, MR is the best imaging modality for the assessment of the pituitary gland. Microadenomas are best seen on coronal T1 weighted images as focal areas of hypointensity when compared to the rest of the pituitary gland. Occasionally, they may be isointense or even hyperintense on non-contrast studies. Other associated features include deviation of the infundibulum, asymmetric convexity of the pituitary gland, and mild downsloping of the roof of the sphenoid sinus. In general, administration of gadolinium contrast increases the conspicuity of these often small neoplasms, which are revealed as hypointense foci within the gland on immediate post-contrast scans or as hyperintense foci on delayed imaging. For macroadenomas, usually it's never a problem to visualize these kinds of lesions on the MRI. However, they exhibit heterogeneous appearance with cystic formation or areas of hemorrhage, which makes it difficult to be differentiated from craniopharyngiomas or paracellular meningiomas. Now, macroadenomas most commonly manifest because of optic chiasm or nerve compression, hydrocephalus, cranial nerve palsies, or anterior pituitary dysfunction. These lesions appear isointense to gray matter on T1 weighted images and characteristically produce draping of the optic chiasm over the top of the tumor. Sometimes, there is invasion of the cavernous sinus. Craniopharyngioma is the most common suprasellar mass in the pediatric patients. It shows a peak incidence between 5 to 10 years of age. Now, most craniopharyngiomas involve both intracellular and suprasellar compartments, but majority of which is seen in the suprasellar region. This lesion exhibits different components such as a solid component, cystic changes, and sometimes exhibits calcifications. Rathke pouch cyst is a non-neoplastic epithelium-lined cyst arising from the embryologic remnants of the Rathke pouch in the pituitary gland. Now, 66% of these lesions are seen within the intracellular region and 33% are seen in the suprasellar region. In MRI, this kind of lesion appears hyperintense in both T1 and T2 sequences. Let us now proceed with the discussion of nerve sheath tumors. Now, schwannoma are tumors arising from Schwann cells, which are responsible for the formation of myelin sheath of axons. The tumor is focal, encapsulated, and affects the cranial nerves, more often the vestibulocochlear nerve, which is cranial nerve 8, and trigeminal nerve, which is cranial nerve number 5. Cystic degeneration is common, especially in larger lesions, and may be accompanied by bleeding in 5% of cases. This tumor comprises about 8% of all intracranial neoplasms and is more commonly seen in adults. This lesion usually appears isotohypodense on CT scan, while on MRI, it is best seen in the axial and coronal T1 weighted images cuts through the basal cisterns. It is usually hypointense to gray matter on T1 weighted images and hyperintense to gray matter on T2 weighted images and exhibit intense enhancement on post-contrast images. Now, for the common examples of schwannoma, first we discuss vestibular schwannoma. So it arises from the vestibular division of the 8th cranial nerve within the internal auditory canal, and its most pathognomonic sign is that it causes expansion of the canal. And if this tumor is seen bilaterally, the patient may have a condition which is called neurofibromatosis 2. Trigeminal schwannoma can be identified by its location within the pontine cistern at the mid-pons level near the Meckel's cave. Now, extension through the ganglion and into the foramen ovale, foramen rotundum, or supraorbital fissure may be seen in some cases. Lastly, we will tackle masses of maldevelopmental in origin. Epidermoid and dermoid cysts are uncommon congenital masses that result from enclosure of ectodermal elements when the neural tube closes. Epidermoid cysts account for about 1% of all intracranial neoplasms, where our dermoids are less frequent in nature. Both are benign and characterized by slow growth. The peak age of incidence is 40 to 50 years for epidermoids and 20 to 30 years for dermoids. Now, both lesions are lined by squamous epithelium and produce large amounts of keratin. The key histologic distinction between the epidermoid and the dermoid is that dermoid cyst contains pilosebaceous unit. More often, these kinds of masses are seen within the midline of the skull base or usually present as midline masses. On imaging studies, epidermoid cysts appear as well-circumscribed lobulated soft tissue masses that, because of the presence of solid cholesterol and or CSF within the interstices of the tumor, most commonly have signals in both CT and MR that follow that of CSF. Now, dermoid cysts, on the other hand, typically have signal characteristics that follow that of fat, which is low density on CT and hypertense on T1 weighted images with signal suppression of fat suppressed images. They do not enhance unless infected. Arachnoid cysts account for about 1% of all intracranial masses and are congenital in nature. Secondary or acquired arachnoid cysts are in reality leptomeningeal cysts resulting from a previous inflammatory process such as meningitis or a bleed. True arachnoid cysts are created by secretion of CSF from the cells lining the cyst and are therefore intraarachnoidal. The most common location of this lesion is seen within the middle cranial fossa and sometimes can be quite large. Since these tumors are CSF filled, they exhibit CSF signals in both CT and MRI imaging. Thank you for listening.